So hello to all. This is Marie Harvey. I'm the Associate Dean for Research here in the College of Public Health and Human Sciences at Oregon State University. And I want to welcome you to our College Spring Seminar Series with our new adventure of having these presentations via Zoom. Today, our Dean, Javier Nieto, has volunteered to introduce our speaker and to be our moderator of the session. So please welcome Javier Nieto.
Thanks, Marie. Thank you all. And again, welcome to the College of Public Health and Human Sciences Friday Research Seminar Series. We are so glad that you were able to join us for this research presentation via Zoom today. We have now 74 participants already and growing quickly. Before I introduce today's speaker, a couple of housekeeping items. We have muted all of your microphones. If you have a question, please use the chat feature in Zoom. We will be moderating the chat and repeat questions for our guest today. We appreciate your patience and understanding. This is the second of our seminar series in the time of COVID-19. And as we continue to offer these seminars via Zoom, we will refine the process to make sure that everybody has a good time and is enjoyable for everybody. Now it's my great pleasure to introduce today's speaker, Dr. Hilary Godwin, who is joining us via Zoom from Seattle, Washington. You can see all these cherry trees in the background. Dr. Godwin is Dean and Professor of Environmental and Occupational Health Sciences at the University of Wisconsin, Washington, the other UW, I'm sorry, School of Public Health. She has been in that position for almost 2 years. Before UW, she was Chair of Environmental Health Sciences and Associate Dean at the Fielding School of Public Health at UCLA. And prior to that, at Northwestern University, where she was Chair of the Chemistry Department, the first woman to have that position. She obtained her Ph.D. in Physical Chemistry at Stanford University and completed an NIH fellowship at the Johns Hopkins School of Medicine. She has a very long academic and research career, particularly in the field of molecular toxicology of engineered nanomaterials and lead. And in addition, she has a strong interest in community-based approaches to addressing environmental health problems, particularly the impacts of conservation programs and policies in the health of indigenous populations. The topic of her talk today is different though, a very timely one. She's going to speak on the lessons learned from being in the first wave of the COVID-19 epidemic in the United States. Dr. Godwin, thank you.
Thank you, and thanks everybody for joining us today. So here we go. So like most of you, much of my days these days is consumed with COVID-19 related stuff. So I appreciate everyone who is still willing to come in and hear more about it. I'm going to endeavor to sort of give you my perspective from having been in a leadership position in the Puget Sound area at sort of the first wave of the epidemic hitting the United States, and share with you sort of the strategies that we've used here and that I've used to help facilitate decision-making in these very uncertain times. So here you see door number 1, door number 2 on my slide. This whole experience of every day there being new information and having so much change and uncertainty reminds me frequently of an anecdote that one of my colleagues at UCLA told me. And I actually have no idea whether or not it's true, so I'm just going to repeat it to you as though it is, but take it with a grain of salt. So what he told me was that there was a study done by psychologists where they interviewed cancer patients and asked them which of 2 choices they would prefer, whether they would prefer door number 1, where they had an uncertain prognosis, but where the range of possibilities ranged from very good to not so good, or whether they would prefer door door number 2, a certain prognosis, or a very, like reliable prognosis that they could be confident in, but that actually wasn't such a great prognosis. And what he told me in this mystery study that perhaps never occurred, was that the majority of the patients chose door number 2, the worst prognosis that was more certain. And I often think back to that when I'm in times like this where there's a lot of uncertainty, because it reminds me that most people don't like uncertainty. And furthermore, most people don't like having to make decisions in the face of uncertainty. And so it's a good thing to keep in mind as an administrator, because often I get all excited about these possible changes that we could be making, and it helps to remind myself that the people who are living through the daily uncertainty that is engendered by those changes, or the possibility of those changes, are usually not as enthusiastic about it as I am, so that it's important to sort of temper that and be respectful of the fact that they're facing a lot of uncertainty, and that uncertainty for most people is not fun. I should say, however, that I actually am a cancer survivor, and when he told me this anecdote, I thought, that's great, but my experience was I wasn't offered a door number 1 or door number 2. In fact, what it felt like more to me was like kind of like Wheel of Fortune, but kind of like an evil version of Wheel of Fortune, where most of the things that would come up on the wheel were not so great and not things that I wanted. And not only that, but the wheel kept getting spun at various points that I didn't have any say over. For instance, every time I'd go to get a scan to see whether or not I was still in remission, it was not fun. I hated it. So anyway, to me, COVID-19 feels a little bit more like that period of my life, where there's a lot of uncertainty. There's people are talking about a lot of different options in terms of what might happen, but we don't know when they're going to happen, and we don't know which of them is most likely. And so it makes it really hard to make good decisions, either on a personal level in terms of what we should expect and plan for, but also for those of us who are in administrative positions or doing research or just trying to get on with our lives, trying to figure out what's the best path forward given all that uncertainty. So one thing that I keep turning back to in that is, and by the way, I'm totally fine. This cancer was a long time ago, and I am in remission still and have been for a long time. But one of the things that really helped me through sort of the darkest days of that period when I didn't have a good prognosis was a person who was running a support group who said to me, my best recommendation to you is prepare for the worst, but hope for the best. And that really helped me at that point, very dark point in my life, and helped my husband and I say, okay, we're going to sit down and come up with a will, even though we're young adults, and figure out what might happen to our young child if I don't make it and something happens to him, and go through those different scenarios while still holding on to this very real sense of hope that was genuine and helped to sustain us through that period, but feeling like we had a backup plan in case things went south. So I'm going to come back to that as I talk about sort of how I've approached decision making in this current context. But I thought I would offer that all to you on a certain level. I feel like that's what we do in public health, is we prepare for the worst, but we remain optimistic and hopeful and hope for the best, and let that joy in life and its infinite possibilities carry us forward. So COVID-19. So just a sort of reminder of the timeline, I was saying to the folks on the host here before you guys joined the call, it feels like an eternity for most of us. It definitely does for me. It really, for us here in Seattle, began just about 2 months ago, actually more than 2 months ago, like 2.5 months ago, for us, when the first case in the United States was reported here in Everett, Washington, on January 23rd. And that was right around the time that the WHO declared COVID-19 to be a public health emergency, and also the United States instituted restrictions on travel from China, trying to restrict the numbers of travelers' cases. I have to admit, I was following everything between, as that period went on, but probably like most of you, wasn't really thinking like, yeah, this is going to come here and be a real significant life changer for us until about February 19th. And that's when I had my own personal aha moment. And for me, that aha moment was catalyzed by a panel that was put together by our Meta Center for Pandemic Preparedness and Judy Wasserheit and Peter Rabinowitz, who run that center here, to talk about coronavirus. And they brought in just this amazing group of people to talk, including the guy who had treated that first patient, the physician at Harborview who's responsible for their emergency preparedness planning, and shown here on this slide, Jeff Duchin, who's our Chief Health Officer for Public Health Seattle and King County, and Scott Dell, who leads the unit at the Gates Foundation that is responsible for managing the very large commitment. I think it's now $150 million that the Gates Foundation has committed to COVID-19 response. And at that point, Gates had committed $100 million, which seemed like a lot given where things were, and because most of us had seen other concerns about pandemics in the past come and go and not really materialize into something that enveloped our lives the way this one has. And really the thing that was the aha moment for me was when Scott, who was our last speaker, got up and asked, just in his calm and together voice, said, I have a question for all you guys. Just give me a show of hands. Who believes that this thing is coming to Seattle and that we're going to see community level transmission here? And we had just been through this whole series of talks, and so I was one of the people who raised my hand, as many other people did. And then he said, okay, so how many of you believe that this will have such a big impact on our region that the ICUs here in Seattle will be filled with patients? And my hand and a bunch of other people's hands went down. And really, there were only sort of 3 people left in the audience with their hands raised. And one of them was Jeff Duchin. And that was my aha moment when I thought, wow, if there's anyone who knows what's going on here, it's Jeff. And Jeff is worried about this. I need to be worried as well. So that really, for me, was a sort of a sea change moment, which is probably what he was hoping to accomplish. Also, he's just a really honest and straightforward guy. And so that was when, I really started in earnest talking with my colleagues within the School of Public Health about what we needed to do to get ready. And just to sort of provide you with some context here, at that point, we had very little testing capacity that was going on in the United States. So this is a show of number of specimens tested in blue by the CDC labs. And then you can see, like on February 19th, this is before we started having testing being conducted in our state and local public health labs, which is shown in orange. And so even though at this point in retrospect we know, and at that point we kind of knew, that there were probably cases circulating community level transmission in the United States and in our own area, we were kind of blind to it. And here in the Puget Sound region, we were sort of fortunate in that we had a couple of early indicators that things were different. So one of those was that we had the Seattle flu study ongoing, and they actually picked up a community transmitted case right at the end of February. And then the other was that we had some physicians that were seeing patients from a nursing home, elder care facility in our region having surprising symptoms, even though they had not been traveling to to regions that were affected and asked the CDC to do some testing. And so as a result of that, we got some of the first positive tests back showing community level transmission. And that testing came out right before Washington State Department of Health started doing testing, and also the University of Washington medicine was cleared for testing. So it meant that when we did get those community acquired cases detected, and I don't know if you guys are seeing this, I'm seeing some strange lines on the screen, but ignore those. When we saw these first community acquired cases in Washington, and simultaneously you guys reported them in Oregon, and California also reported right at the end of February, that we actually had some limited capacity here in Washington to actually start doing testing as we were doing case contact tracing. And that turned out to be very fortuitous. So with that in mind, we were then received a call from Public Health Seattle and King County, from Jeff Duchin and Patty Hayes' group, asking us if we could deploy our Student Epidemic Action Leaders, or SEALS team. So the SEALS team is a group of graduate students here at the University of Washington in the School of Public Health who are particularly interested in going, for most of them, going into practice. And so they're trained in applied epidemiological skills, including contact tracing, and go through this long training program with Janet Baseman, who's our Associate Dean for Public Health Practice, who leads the SEALS team, and had already been trained, and for most of them had already been previously deployed in local health departments here in Washington when we had smaller outbreaks. And so they were used to working in a practice environment. They were used to serving a surge capacity, and really were absolutely poised to be able to help with the COVID outbreak. There we go. Okay, so in terms of the response to COVID-19, that's meant that Janet was able to mobilize 30 current and former SEALs and have them deploy almost immediately to assist with contact tracing at Public Health Seattle and King County and the Washington State Department of Health. They were helped with symptom monitoring of return travelers before we started having community transmission. They provided data support for case investigation and laboratory testing, and helped boost our laboratory information management system, our LIMS system, for the Washington State Department of Health in anticipation that we would need to be able to do testing here. They assisted with notifying infection prevention about confirmed cases at local hospitals, contact tracing, and then once we started seeing drive-through testing here, providing technical training and support. And most recently, they've also been helping with our own University of Washington environmental health and safety with their contact tracing that they're doing as well. So they've been absolutely invaluable. It really is a good lesson in how having students who are, a team of students who are trained for really working in health departments, and having that. Janet has this long history of working with, which is why she's our Associate Dean for Public Health Practice, has a long history of working hand in hand with practice partners. Being able to just easily move into that kind of helping situation really made a huge difference. We, like probably you, have had a large number of people in our community offer to volunteer in the response. And Janet's been really critical in terms of explaining, you know, they need people who can commit 40 hours a week. They need people who understand how to do contact tracing. They need people who are willing to work on site at the command center. All those kind of things, really helping us to understand from the perspective of the health department what's helpful to them, and keeping us from, like, me when I'm like, oh, that's a great idea, but she's like, that's great, but they don't have time for that right now. You need to wait until they actually need something from you before you offer yourself. So anyway, she's been absolutely fantastic, and it's been a wonderful program. She is right now working on trying to scale this up as we have different governors talking about creating armies of contact tracers. So keep your eyes posted for the Northwest Center for Public Health Practice. We'll probably be pushing out trainings both for local health departments and for other units to provide training for people who need to rapidly come up to speed on contact tracing. Okay, so at that point in early March, this is sort of what we looked like in King County. And I just want to point out, these are not real epidemic curves, because these are when cases and deaths were announced by Public Health Seattle and King County, as opposed to when they were actually symptoms started. But you can see that we were on this upward tick in terms of cases, although still pretty low levels of deaths, and unfortunately, most of those deaths early on were in individuals who were from a series of care facilities around the region. So people were particularly vulnerable because of their age and also prior conditions. But we were really worried about what the future held, as were probably a lot of other people, but we're just sort of a week or two ahead of much of the rest of the country. And the big question that we got from the leadership team at the University of Washington at the time was, given all this, how can we encourage our faculty, staff, and students not to show up on campus if they're sick? We'd like to believe that people don't come to work or go to classes when they're sick, but the reality is that we, for the most part, don't really incentivize that behavior, or haven't in the past. So for instance, you know, our big introductory courses for our undergraduate public health majors there's a heavy emphasis on participation, because we want them to interact with each other and to engage. And that runs counter to asking them to stay home if they're not feeling well. And likewise, we weren't really forcing people to stay home if staff and faculty if they were sick. People would come in if they had sniffles. And so that was an issue, like how can we start changing the norms in ways that will benefit the health of our community. And then we also started to have questions about who should we let work from home early on. You know, if we're letting some people work from home because they think they might be sick, do we need to actually ask if they're sick? Could we just let people use their best judgment? In which case, you know, what if we need them here, or is there going to be inequities? And then we also were worried about this question of, should we switch to online instruction? So we had some instructors saying, hey, I don't feel comfortable because of my own health conditions teaching in front of a large class. I want to switch to online. How do we manage that transition? So some approaches that really helped guide decision-making and communications during that period and continue to be very helpful. I would say the first one is one that's very core to sort of our leadership philosophy at the University of Washington, which is this establishing guiding principles and core institutional values, and then referencing back to those when we're making decisions and communicating about those decisions. So an example of that is one of our core values is equity and inclusion. And so it meant that when we started talking about switching to online instruction, we really carefully looked at how that was going to impact, for instance, our students on financial aid. That was less of a problem when we switched for winter quarter at the last minute, because there's more flexibility to switch to online for a short period of time. But it was a huge part of the decision when we were making the decision about whether to switch to online for spring quarter, because at that point, we could have put our students' financial aid in jeopardy, and our ability to get financial aid out to them quickly in jeopardy if we delayed our start. So those were all things that anytime we'd make a big decision, that we'd look at not just sort of what's good for the average person on campus, but also what works for our most vulnerable populations. Another really critical one was this core idea of not getting out in front of central messaging. So we have a really strong integrated communications team here at the University of Washington. They are the people who constant learning remind us that the core is what our values are and that we need to make value-based decisions. But they also remind us it's really important that we be consistent about messaging, because otherwise people get confused and it looks like we don't have our act together. And so we really worked hard across different levels in the university to try not to get out in front of central decision-making and central messaging, and created a decision-making structure where decisions were made in consultation with our advisory committee on communicable diseases and a leadership team, then communicated out to our board of deans and chancellors, and then pushed out from there, so that when messages came from the provost or president, that the next layers of leadership down knew what the messaging was going to be and could echo that in their own messaging. And for some of the units that meant a push out approach. For instance, in our vice provost for research, her experience was that people didn't tend to open up her emails. And so she's used a messaging scheme where she messages to the associate deans for research in each of the schools, and they use their network to push out messaging, which gets a better open rate. So anyway, I throw that out there. It's been really helpful for us, and has been a good lesson in terms of how to make sure that we keep people on board with the decisions that we're making. And I provide for you guys here some references in terms of our school coronavirus website, the campus one, and the King County one. We've been working really hard to make sure those are all in alignment and up to date and consistent with each other. Okay, and at that point, one of the big things we were communicating, as I'm sure you were as well, is this overarching goal of flattening the curve. And so there, I think initially most of us sort of emphasized this idea of our goal is to flatten the curve so that the peak number of cases doesn't exceed the carrying capacity of our healthcare system. I, as a public health person, also found that some of the things that were lost in cartoons like this were other implications of flattening the curve, like that it pushes out the time of the peak, which is great in terms of allowing us to build extra healthcare capacity, but also is confusing to people who are expecting to see a wave hit and then sort of see this delay. And then also later communications when we started getting more information. One of the things that really helped inform our decision-making as well as the governor's decision-making was some early modeling that came out for the Institute for Disease Modeling, which is funded by the Gates Foundation here in the Puget Sound area. And they did some modeling specific for us in King County, looking at what different kinds of caseloads we could expect from COVID, depending upon whether or not we instituted societal level restrictions on social distancing or social gatherings and forced social distancing at a community level. And this curve where they showed that we could reduce what was a predicted number of cases by early April of about 25,000 cases down to like 1,700 cases was a big part in our governor's decision to close our schools and to limit large gatherings. And is one of the reasons those early decisions, which you see sort of coming sequentially, University of Washington being the first major university to announce switching to online because we were sort of at the epicenter at that point. Washington State restricting gatherings, Washington closing K-12 schools, followed closely by Oregon closing them, and then both states declaring stay-home orders. Those were all triggered by these modeling studies that showed, like we had seen generally from the pandemic flu preparedness plans, that if we instituted these large changes that we could expect much fewer cases. So we, like many of you, there was a little bit of whiplash with having all these different announcements coming out sequentially and not being really having much heads up ahead of time about which ones were going to be leveraged one. Some things that helped us in terms of managing those big transitions, I would say the first one was that we got a commitment early on from our senior leadership at the University of Washington to stay in step with the guidance from Public Health Seattle and King County, which was really critical because Public Health Seattle and King County and Washington DOH were who the governor listened to and our local elected officials listened to. And so while they were balancing societal needs with sort of the public health perspectives, they generally followed sort of in lockstep the pandemic flu preparedness plan for non-pharmaceutical interventions. And so it gave a good roadmap in terms of what we could expect. Some other things that helped were that myself and Janet Basement served on the COVID leadership team for the campus that was making recommendations to the president and provost, and Janet served on the advisory committee on communicable diseases and still does. That helped us to provide sort of explanations or interpretations of what the public health guidance meant as the team was making decisions in real time. And then finally, two things that we implemented at the local level within our school. One is very early on, we started using surveys to assess needs for working from home and learning from home before the guidance that we needed to do those things was issued. And that allowed us to plan and figure out who we could allow to work from home and be much more proactive about that. And then we also did a survey later on similarly about research needs and concerns, which again let us get out ahead of some of these questions about like what's going to happen. We felt much more like we knew what we needed in order to be able to respond if those changes were put in place. And then finally, as I mentioned before, we've been running weekly COVID-19 webinars that I run those, but I have a whole panel of people that rotate through and join me. We provide updates on not just what's happening nationally and locally, but also what decisions are coming down the line in the university, why those decisions were made, what we can expect in the coming week, like what are we discussing now, and then answer people's questions about what, how it impacts them and what the school is doing about it. And we've also had visitors come in and talk about modeling studies and wellness and things like that that have been very helpful. Okay, so after that sort of onslaught of things, at the end of March, we reached a point that all of us sort of drew a deep breath of relief, which was that the modeling studies started suggesting that the social distancing efforts were working in Washington and that we were seeing a flattening of the curve. Shortly after that, in early April, April 6th, Washington hit the peak in daily deaths, and I'll show you Oregon, we think, peaked shortly thereafter. And so that has then led us to this sort of like what next phase. I think one thing that it's worth acknowledging is that, you know, it's complicated because COVID-19 is hitting different regions of the United States at different times. So here comparing, this is, I provide the link here, this is the Institute for Health Metrics and Evaluation. They have a great website, interactive website, where you can pull down for individual regions of the country or different countries and look at both need for hospital facilities, but also in this case, in the red lines, the number of deaths reported on a daily basis, and then based on that, what the projections are in the dotted line going forward with the shading showing uncertainty. So on the left, we have Washington, on the right, Massachusetts, just so you can see, you know, the sides that are the y-axis scales are totally different, that Washington, whereas we have passed the peak, Massachusetts is really just at the beginning of the curve. And that means that any lifting of those restrictions is going to need to be done at a local level, just like implementing them was, so that because of doing things nationally would give us a very scattershot in terms of response. It doesn't make sense for Massachusetts to be doing the same things that we are. And just to show you sort of where Oregon is in this. So Oregon, similarly to Washington, we believe peaked in early April. A lot of more uncertainty, but you guys have a really small amount of cases, deaths, and relatively small number of cases compared to many regions. So yay for Oregon. Just to compare, again, the real huge discrepancies by region. New York, as we all know, just similar timing to Oregon and Washington, but just a huge, huge number of cases and deaths in New York City, showing really high variability from place to place. And some of that has to do with local infrastructure and vulnerabilities, but some of it also has to do with how different states are handling the pandemic differently. And that's just as a reminder, going back to your social studies from 5th and 11th grade, that because of federalism in the United States, protecting public health and safety is one of those rights or powers that's reserved to the state government. So it's not that there's no role for the federal government, but it really is a local decision. And that's great because it means we can react in real time to what's going on a local level. It also means that we have, like with everything, whether it's fluoridation of water or vaccinations, or in this case, response to COVID-19, huge differences between how different states are reacting. Okay, and so what are we hearing now on the public health modeling is, and this is a cartoon version of it that I love, is really clear in telling us that it's really critical for us to stay the course in terms of social distancing restrictions, because otherwise we risk having a resurgence of cases. And then the question that always people ask is, but how long do we have to do that for? So you saw guidance coming out of the White House yesterday suggesting that for local regions, once we had been on a downward path for 2 weeks within a local region, that we could start to transition to lifting some of the restrictions. That's not really what most of the public health models are suggesting. And this is a great study, and I know an overwhelming figure, from the Harvard Chan School of Medicine, School of Public Health, where they looked at the effect of changing the length of time that social distancing restrictions were in place. So that's these blue shaded areas. And then in the different colors in each one of those different scenarios, looking at different levels of social distancing restrictions. And what shows quite clearly is that you can have, if you let up on the social distancing too soon, that you can have a second peak. In some cases, it can be even higher than the first one. So, so that, of course, is what we're worried about. In terms of what can we learn from countries that are ahead of us on the curve, one really interesting outcome that we've seen from China and South Korea is that they've used mobile mobile devices and big data to collect data that allows them to monitor movements of people and assess whether or not they're breaking quarantine. That's proved super helpful as a sort of digital version of contact tracing. Whether or not that's acceptable here in the United States is another question, but it's definitely something that we now are seeing Apple and Google talking about implementing here. So given all of these big questions that are still left of what should we do next, how do we make good decisions with that incomplete information? And here's where my coming back to that, hope for the best, but prepare for the worst. My more academic version of that is in these very uncertain situations, what I've found to be very helpful is to develop different scenarios. So both a best case scenario and a worst case scenario, and then also some intermediate scenarios, and then say, what would we do under those different conditions? And sometimes it's that we do the exact same thing, and so then actually you can move forward. Other times you would behave very differently under those different scenarios, but at least knowing what might happen for me has been something that helps in terms of moving forward. So I'm going to give you a disclaimer right now. After I developed this whole thing, then the White House came out with their guidance. So my scenarios do not map exactly onto the phases described in the new White House guidance. That makes sense because I'm telling you from a purely public health perspective, here's the way that I would sort of map this out. And obviously, elected officials are not just worried about what's happening from a public health perspective. They need to look at other societal factors, such as the economy. And so you'll see a range here between sort of public health and I would say a more economically oriented approach coming out of the White House. I'll try and call attention to where those differ. They aren't totally inconsistent with each other, but they aren't completely aligned either. Okay, so I think when you're thinking about these scenarios from a public health perspective, it's really helpful to think about why we ended up using social distancing in the first place. And the reason for that was that we didn't have our normal toolkit that we have like for seasonal flu. So we didn't have a vaccine. Our testing capacity was really limited. And then there were other things that were specific to this new disease that were really unfortunate. The big ones are that the good news of only 80% of the population, that 80% of the population has mild or moderate or no symptoms, means that we have a lot of people who can be asymptomatic carriers who are transmitting the disease. And that makes it really hard to do case contact tracing and to quarantine affected individuals. Conversely, the other 20% of that, that we have such a large percentage of people who are affected who have really severe symptoms that require hospitalization is hugely taxing on our hospital system. And so we're all striving to keep the number of cases in a range where we can provide effective treatment for everybody. So those things are still true, just as they were when we started our response 2 months ago. So what does the best case scenario look like? Under my definition, best case scenario is that we have an effective vaccine that's widely available and deployed, or alternatively, that we have an effective therapeutic that prevents or ameliorates the most severe symptoms associated with COVID-19, and that is widely available. And this is where the asterisk is the world according to me, as opposed to the White House. What I would say from a public health perspective that you could reasonably expect under this scenario is, of course, we're going to have massive vaccination campaigns and all the complexities associated with those that we have had with vaccinations in the United States to date. But in general, return to work, return to school, having large public gatherings being allowed again, probably largely unrestricted travel, but really being faced with these lingering impacts of the economic downturn. The problem with that is that the timeline for vaccine development is long. And so we're talking about at least 12 to 18 months from now. And so then the question becomes, what are we going to do in the meantime? So that's where the intermediate scenarios become helpful. So I define the intermediate scenarios as we have widespread testing available, ideally for both current infections and prior infections, and also that our case contact tracing capacity is greatly enhanced from what it is right now. So I just want to point out, in that ideal intermediate, well, not ideal, in the intermediate scenario, we need to have both the ability to test for current infections, which is what we've had so far for the most part. That's PCR-based testing. But we also need to be able to test for whether people have previously been infected and hence are unlikely to have severe symptoms going forward or to be able to transmit it. And that requires antibody-based testing, which has just become available this month. So first FDA-approved test came out on April 2nd. So in the world according to me, what might you reasonably expect under this scenario? I think reasonably under the scenario, because we still have a large segment of the population that's immunologically naive, and we still have cases circulating, that you would expect continued guidance and protections for those who are most vulnerable to severe symptoms. But we will see phased in return to work and schools. and fewer restrictions on travel. So probably restrictions on travel to those areas that still have severe outbreaks, but less restrictions on other types of travel. Here's where I really differ from the White House recommendation. So my prediction was no large public gatherings without social distancing, which would mean things like our fall football games would have to proceed without live audiences. And then I think importantly, the possibility of reinstating restrictions on a rolling basis if we start to see too many cases. As a reminder, the groups that were identified early on as being more vulnerable to COVID are people who are age 60 and above. Current CDC guidelines are for 65 and above, but Public Health Seattle and King County is 60 and above. Individuals who have prior heart disease or lung disease, diabetes, high BMI are all more vulnerable to severe symptoms associated with COVID. And we're starting to see emerging evidence that some of the most vulnerable populations in the United States who have less access to regular health care or who have higher rates of other pre-existing conditions, that those populations are being disproportionately impacted by COVID-19. And so, you know, this is something that was brought up early on by people in the public health community, but that it's not just that, you know, this is reinforcing some of the health inequities that we already have in place and social inequities that we already have here in the United States, and really pointing to the need for us addressing some of those upstream determinants of health. And also those same individuals are often more likely to be economically more disadvantaged by the outbreak as well. So all of that is not good. Okay, so finally turning to the worst case scenario, I define this as kind of where we are right now once we return closer to baseline. So right now we don't have large scale testing for current infections or prior infections. And we have pretty limited case contact tracing capacity compared to what would be needed. And so, from my opinion, what you could reasonably expect from a public health protective approach under this scenario is continued guidance and protections for those who are most vulnerable to severe symptoms, a more limited phased-in return to work, continuing having restrictions on travel, particularly while we have other parts of the country having outbreaks or at the peak of the outbreak. And what we've heard from our governor here in Washington is to expect not to have school and not to have large public gatherings during this period of time, because those were the things that made us most vulnerable to transmission. So just as a sort of final note, these scenarios, I developed them sort of as an either or, but they really can be viewed as a roadmap or timeline, where right now we're still in this phase where we're waiting for local return to manageable levels of COVID. And once we get there, we'll start phasing into this period of time where we're still restricted in terms of our testing capacity and contact tracing, and so may not be able to lift very many restrictions. So the governors of our 3 states on the West Coast are pushing together to get to this stage where we have widely available testing, which I called our intermediate case. And the president's plan sort of talks about how we might more quickly move past that, even if we don't have a vaccine. Okay, so what to remember until we return to manageable levels of COVID-19. The really important things are, during this period, we're still under stay home, stay healthy, but continue to connect with people. And I add to that, that in a world where you could be anything, be kind. Be kind to other people who are stressed out by this situation. Be kind to yourself, because this is a lot that you're going through, and be patient with yourself as we're going through this process. And then I think I'll stop here instead of talking about this choosing the right mask for the task, but I'm happy to come back to it in the questions. And just sort of end there with a comment of thank you to all of our public health practice partners, and of course all the healthcare professionals who've been working so hard over the last couple of months to keep us all safe and to return us to a wellness state. We're incredibly indebted to you. Our gratitude is hard to express. They've really done a tremendous job. And then finally, thanks to the unsung heroes of COVID-19, whether it's the people who are picking up the trash or making sure that we still have, sanitation and water running, our Uber drivers who are delivering food from the restaurants that are still open, the people working in the grocery stores, or just you guys who are staying home and doing the right thing and staying healthy. Okay, so happy to answer questions.
Thank you so much. So I think I'm the only one that can applaud here.
Thank you, Javier.
Thank you so much for a very great talk, Hilary. So I remind everybody that please write your questions if you have any in the chat room, and I will be reading them to Hilary. In the meantime, I may ask you a question. I'm going to start with a question about testing. So you talked about PCR and antibodies. Of course, the antibodies, my understanding is that we still don't know really well what's going to be the duration of immunity, whether it's going to be short-term, long-term, how is the curves of IgGs and IgMs, and we still don't have much data on that, and whether immunity would eventually go away and people could be reinfected again. That's one question.
Yeah, you're absolutely right. We do not know those things. Again, best case, worst case scenario. The worst case scenario is that there's some suggestions that people could get reinfected. I'm sort of holding out hope that maybe that was just because we had poorly controlled testing. But the real reality is that is not uncommon for many viruses and could inhibit our ability to make a vaccine as well. So, but we need that testing to be able to figure that out. So hopefully that information will be coming out.
One more question on testing. So in the future, how will you see the priorities for testing those seeking care, vulnerable populations, certain occupations that are particularly exposed or could expose others? And what's the role of testing in surveillance, population surveillance?
Yeah, so, I would say I don't feel like we've been able to do surveillance so far, just because the testing capacity has been so limited. And so getting to the point where we could start to do some surveillance and get some real sense of what the prevalence is would be fabulous. We're starting to see here, I just heard UW Medical Center is now testing everyone who comes into the hospital so that they know whether or not at the time they're admitted that they have a high enough, I wouldn't say whether they're infected, whether they have a high enough viral load to show up as positive on a COVID test. And as we all know, the problem with the testing that we have, which is just a reality, is that it doesn't tell you, it just tells you that at that point in time, you don't have a high enough viral load to show up positive, which is why we've been prioritizing testing people who are symptomatic. But it'd be really great to get some surveillance studies to look at what percentage of asymptomatic people we have out there, so we could do a better job of having a sense of how much transmission is going on in the background. But we need to not just have more testing, we have to have more smart testing as well.
Thank you.
Smarter testing.
A question from Nicole. Thank you for your presentation. What societal changes do you think will remain long-term after the crisis is over in the field of public health, but also in other facets of society?
Yeah, so, I've seen some interesting pieces that sort of suggest that it's sort of, it's not that reality has changed, it's just that our perception of reality has changed. But I think for a lot of people, it's a longer term impact is just a disruption of their feeling of security in terms of not worrying so much about infectious diseases. So I guess for better or for worse, I anticipate that people will feel more afraid about exposures. And And that could come with some good changes in practice. Like I hope it means that we end up developing a system where people don't come to work sick, because it's not good to transmit flu, let alone COVID. So that could be a positive outcome. Certainly changes we hope will be sort of a shift more towards these sort of prevention societal level approaches, of recognition of the importance of those.
Thank you. A question from Marie Harvey. Can you say more about vulnerable populations and how we can serve individuals who cannot stay at home to stay safe, homeless, domestic violence, etc.?
Yeah, you know, I feel like this is something where this is a problem that we had before COVID, and it's only gotten worse with COVID. You know, the optimist in me, the part of me that remains hopeful, hopes that this shines some light for society on social inequities and health inequities, and why those are troubling for us as a society, and we need to care for our most vulnerable, and hopefully causes some policy shifts in that direction. Here in Seattle, we have seen some really strong responses in terms of providing care for homeless individuals and housing for homeless individuals who to provide social distancing. And of course, I would hope that those would not just last, but be augmented upon, but it's hard to predict.
We have one more question, time for one more question from Amy Young. Do you think that COVID-19 will remain endemic in the population long enough to a vaccine to be a viable goal for preventing transmission, given how long it will take to develop a vaccine?
So I don't think it'll remain endemic, I don't think we'll have a continuous presence of transmission of COVID-19 in this region for the period of time that it would take to develop a vaccine. However, I do think that there's a significant possibility that we'll see this virus start to cycle seasonally, in which case it could come back on a yearly basis. And so having a vaccine could be very helpful if we see a seasonal resurgence in the fall and winter or in future years. You know, even as we're on this downswing of the curve and feeling pretty happy and good about it, we definitely need to still be focusing on developing a vaccine.
Well, I think we are time's up. I would like to thank everybody for participating. We had up to 96 participants at some point during the talk, and very especially thank Hilary for a very inspiring talk and very informative. Thank you very much for spending this hour with us.
Yeah, of course. Thank you so much for inviting me, and I look forward to a time when we can be together in person and I can come down and visit you guys in person.
Great.
So in the meantime, stay well, stay healthy, and stay positive and hopeful, because hope is what gets us through these difficult periods.
Thank you so much.
Bye.
Bye.